Thanks again for the opportunity to be here. It is a pleasure to not only be out and about, to be able to see people, but also debate. Roxana, who Dr. Mehran is a leader in this area, so I will try to do it justice. These are my disclosures. So rules of engagement for a debate, I feel like I'm going against conventional wisdom these days. I'll take about 7 minutes and make 5 points. I think you're going to see some of the same studies and slides. And so when you see the same data and people are debating, it's just a question sometimes about how you interpret the information. And sometimes you'll see the same. You could take either sets of slides, I suspect. So let's agree on why we do things for patients. It sounds crazy for the debate, but it's to make them feel better, improve their quality of life, reduce symptoms, improve well-being. To avoid unpleasant events, we could say that's hospitals, MI, stroke, limb loss, potentially some sorts of bleeding that might get you to the hospital, to make you live longer. Dr. Califf told me that in the Duke CCU in 1997. I've added the 2021 edition, or you could have said even before then. Save them money, similar outcomes with less cost. So theoretically, when we're having a debate about what somebody should be on for antiplatelet therapy chronically with coronary disease, that should potentially play a role. I think it's hard to argue that the evidence today says a reduction in the duration or intensity of antiplatelet therapy is a winning strategy. In fact, one could argue we got here because we had a concern after drug-coated drug-eluting stents that we would need dual antiplatelet therapy forever after a late stent thrombosis, but with second and third generation devices, that may not be the case. But if we weren't thinking about a stent, what would the evidence be for antiplatelet therapy? So here's the main theme, I think. If you're thinking about a patient with cardiovascular disease, we're moving from a platelet-centric world to a less antiplatelet-centric world, and maybe a better antithrombotic world. Chronic CAD, and I'll just remind us that we've studied monotherapy aspirin versus clopidogrel. And we've now seen monotherapy, ticagrelor, and clopidogrel post-stenting in the last year. Dual antiplatelet therapy, I'm sorry, I shouldn't say monotherapy, dual antiplatelet therapy. And then it's worth recognizing before the DAPT trial, there was the Charisma trial, chronically looking at aspirin and clopidogrel versus aspirin. And then recently we've had the DAPT study, the antithrombotic therapies with low-dose rivaroxaban, and post-PVD, and I'll talk about some of the ACS data too. So here's Capri. 3 years, 19,000 patients, now 20 years old, published in Lancet in 1996. Clopidogrel chronically was better than aspirin, but it was about 0.5% absolute risk reduction better than aspirin. At that time, clopidogrel was very expensive and did not get chosen as the monotherapy. Aspirin did. So since then, we've gotten new antiplatelet therapies, ticagrelor, prasugrel, others. The idea that you would change one of those out for aspirin is the sense of this debate, and I start with what clopidogrel gives you, which is real and certainly an important advantage, but a small one. You would have to treat upwards of 220 patients chronically to see one reduction in event. How about 2 drugs versus 1? This is aspirin and clopidogrel versus aspirin alone, again in chronic vascular disease after stenting, following patients greater than 1.5 years to 2 years after an MI. Again, this event rate was 0.5%, 18,000 patients. There were some diabetic patients in here. This did have increased bleeding with the dual antiplatelet therapy. Looking at actually gusto moderate bleeding, significantly increased. So I would say 2 versus 1, similar efficacy, and Charisma, increase in bleeding, probably still just stay with aspirin. Roxana Mehran has presented these wonderful data published in the New England Journal. How about dropping aspirin? This trial, as you all know, and other data that have now been published, as you've also done with Xience, stopping the aspirin either at stopping 2 therapies. We'll talk about what you stop at 3 months here, the ticagrelor and aspirin arm versus ticagrelor and placebo, dropping the aspirin and following these patients. And a compelling finding in a reduction in bleeding, BARC 3 and 5, you can see a 1% reduction. Gusto moderate or severe, you can see about a 0.7% reduction. You can put that into the DAPT sort of perspective I just showed you with Charisma. And here's the key secondary endpoint of death, MI, or stroke, things that would bring the patient to the hospital, having events. Again, very similar rates between the two. So no harm dropping aspirin potentially, but aspirin versus ticagrelor. And I said compelling with a mild reduction in potency, dropping aspirin rather than dropping the P2Y12. A high bleeding risk, high PCI patient, risk patients, but the event rates were still somewhat low, I think, likely due to randomization at 3 months. Point 4, here's the overall weight of available data. To date, all the studies on top are the ones where there's 3 versus 6 or 6 versus 12. All of them in the DAPT design, at least at that point, was dropping the P2Y12 and keeping the aspirin going. The below aren't all the studies. You're going to see some more probably with some of the stents and others, and that's aspirin discontinuation. And here's some more of those that you can see again with different durations of aspirin. But the take home for me is it's pretty clear 2's not better than 1. The debate is just which one do you continue on? Ticagrelor versus aspirin. If you drop aspirin, then you're saying I'm going to give one of the stronger agents long term. Well, what is the monotherapy standard of choice? I think it's the one the patient can take. And at the end of the day, what can the patient get and take? And so you've seen these several sets of updated guidelines, many of which have posted and said at some point you can stop. I think even now at ESC, there'll be another trial potentially that'll have data for us on DAPT-1 versus 3 months after after stent. And after ACS, as you've seen, even out to 1 year, if you can keep the ticagrelor going and dropping the aspirin, doesn't seem to be harmful. So I think we're probably debating on the same side of the street, probably. We're saying, yes, you don't need dual antiplatelet therapy, and the antiplatelet you should use might be ticagrelor or aspirin, and the decision might be based on patient risk. So I'll start by putting it together this way. It's generally clear in our platelet-centric world, the world has changed. DAPT in general for long duration with 2nd and 3rd generation stents is not needed. Even in ACS, DAPT duration might be shorter. Shorter duration is now being evaluated 1 versus 3 months. I told you that master DAPT might be at ESC and others. We've seen other studies like this with STOP-DAP2. We've also seen it with some of the stent studies. I believe likely aspirin or clopidogrel, now that it's generic, stays long-term monotherapy due to the dose knowledge we have, knowing the chronic dose of that therapy, the ongoing evidence, and the price to the patient. So like all procedures and decisions, who knows what the right one is? You're going to have to personalize it for each of your patients, but thanks for the opportunity to have this debate.
So thank you for that. And I think we are going to say basically the same things. I love that you started with a philosophical discussion of Rob Califf, let's do good things, making people think, oh my God, he's going somewhere really great with aspirin. And so I'm here to say that today's the day, and these are the days that we have to say that less is more. And less is more for many of our patients. And you might say you want to save money because you're going to give them a cheap therapy, but that cheap therapy, if it's aspirin, it could be hurting our patients. And we are seeing that over and over again. 20 plus years ago, we saw that in the trial of the Capri trial, clopidogrel was superior to aspirin. That was 20 years ago, and we revisited that this year at the HOST-MI. I'm not even going to talk about my study, but the study of the HOST-MI, where a HOST exam study in Korea in 2021, ACC, hot off the press, just a month ago, where 5,000 patients in Korea were randomized after a certain period of dual antiplatelet therapy, 6 to 12 months. If they were event-free, they came in and they got aspirin versus clopidogrel. They were followed for a year plus, and they found less bleeding with clopidogrel and less clinical events, even in the same arena. And to me, that's a superior benefit of getting away from aspirin. And why is that? Because we have gotten so much better in our medical management of our patients. In the past, when we saw that incredible benefit of aspirin for secondary prevention, when you saw the antithrombotic trialists where there was a huge benefit in reducing stroke, MI, with aspirin, it was fantastic to see. And that was based on the fact that the background therapy in our patients was very small. In fact, they didn't have PCSK9 inhibitors. They didn't even have statins back then. And so now we have treated the risk profile of our patients with these wonderful drugs, such that the absolute reduction of events by aspirin, that absolute risk reduction is now minimized, and it's no longer showing that kind of effect overall. And we also have now better novel antiplatelet agents like ticagrelor and prasugrel. And in presence of those potent agents, aspirin is doing nothing but sloughing the GI tract and causing GI bleeding and other types of bleedings. These have been very well described. And in the past 2 years, we have seen over and over again data now switching, instead of going to aspirin monotherapy after a period of DAPT, to P2Y12 monotherapy, even with clopidogrel monotherapy in trials like Stop DAPT, which was in Korea, 3,000 patients, 3 different stent platform. And they showed in the SMART DAPT study where there was absolutely no difference in the ischemic events and a huge reduction in bleeding with clopidogrel monotherapy versus DAPT. When we looked at the Stop DAPT investigators with the Science platform, after a 1 month of dual antiplatelet therapy compared to 12 months, 1 month of dual antiplatelet therapy going to clopidogrel monotherapy, showing exactly the same results. A reduction in NACE, but all driven by reducing bleeding complications. In Twilight, you saw reduction in bleeding complications going to ticagrelor monotherapy after a 3 months of DAPT compared to 12 months. Absolutely no difference in the ischemic events. And when you go to TICO, I just gave you 5 studies, TICO study that had STEMI and non-STEMI patients. There was a reduction in bleeding without change in ischemic events again. And when there was a meta-analysis by Michelle O'Donoghue in Circulation in all these 5 trials showing that P2Y12 monotherapy is beneficial in reducing bleeding after ACS and PCI. They looked at both of those parameters without increasing ischemic harm. And in fact, the ischemic events were lower with P2Y12 monotherapy compared to DAPT. So there's no question that that is the way to go, that we need to go into a place where we are now thinking of a more novel strategies for our patients. Now, the flip side of the coin is the COMPASS trial, where there was an aspirin-free arm with rivaroxaban at 5 milligrams versus alone, versus rivaroxaban 2.5 milligrams plus aspirin versus aspirin. And of course, it was the Riva plus aspirin arm that actually was the most beneficial one of all. And so you might say that it's not like we're burying aspirin, but I'm just saying that we're probably retiring aspirin. And retirement is actually a good thing for these old drugs, that perhaps it gives us an ability to think about some novel strategies moving forward. And that's my debate.
As well done without any slides. Fantastic. The only one point I would make, which I think is the fundamental question with all antiplatelets, antithrombotics. Do we believe there are drugs that can keep you from clotting and make you bleed less? That seems unlikely. So if you have stronger agents, you're always making a trade-off. And we just have to make that decision of what that trade-off is. I think the second thing is in all the more recent DAPT, because I showed pre and charisma, because before stenting, really before clopidine and clopidogrel, before stenting got to DAPT, there's no indication for DAPT until ACS and stenting gets there. Yeah, all the dropping ones have to have it on for a month or 3 months.
I agree with you 100%, but remember one thing. There are patients where we want to give them a potent agent for a longer period of time. Those are the acute coronary syndrome patients and STEMI patients. And we know that we are, by giving them dual therapy with aspirin plus ticagrelor, which is currently a class 1 indication for those patients in the European guidelines, 2A in the US guidelines, we're having a lot of issues with bleeding. We see that exactly. So if you want to give them the potent agent for a longer period of time, take the aspirin off. And that's what the 2A recommendation in ESC for ACS patients are. In select patients, given that benefit, you can allow a longer period of treatment with a potent agent that's going to be helpful in that very high plaque burden patient, and keep them away from the bleeding episodes with GI tract bleeding, et cetera. And I think
Absolutely
that's
agree.
the kind of thing, the novel strategies that are coming forth, switching it off, going to clopidogrel, de-escalating, maybe using platelet function testing. And we certainly know that in AFib and PCI, get that aspirin off as fast as you can, because you absolutely will be saving a lot of bleeding complications. So I think I won the debate since I'm moderating, but no. Thank you so much. I think we both are saying the exact same thing. And now we move to the second debate, and hopefully the slides are uploaded. The second debate is really interesting. We have two world-renowned physicians here, from one Bill O'Neill, who doesn't need any introduction. And of course, to me, Holger Thiele doesn't need any introductions with all of his incredible work on PCI and cardiogenic shock. So let's start with Bill O'Neill.
Thanks very much, Roxana. I'm delighted to be with you this afternoon. I'm a little afraid to combat Dr. Holger Thiele, who has done all of the seminal cardiogenic shock trials that's been done across the world in the last 20 years. So I will give it my best. Again, we're trying to inform and entertain. Just after we got done with the last case, I got an urgent phone call from a friend of mine who's a medical executive in a company in California. He tells me one of his employees, a 51-year-old man, diabetic, that came in 2 nights ago with an acute MI to an outlying hospital outside of San Francisco, and then started to deteriorate. They had a primary angioplasty, transferred to a larger center, and now has been placed on ECMO because he was deteriorating as in cardiogenic shock. So as we get better and better at treating STEMI, the mortality for STEMI is less than 2% now routinely across the world, across America. But the mortality for acute myocardiogenic shock really hasn't changed very much in the last 30 years. And as we get better and better with STEMI, the mortality for myocardial infarction is now largely going to be related to cardiogenic shock. So it's a very pertinent topic, and I think it's something that we all are going to have to focus more time and attention on. These are my disclosures. I want to go back 20, 30 years when we started doing angioplasty trials, and this is in the early days of randomized clinical trials in primary angioplasty. There were 4 trials: the European Cooperative Study, the U.S. trial, and another European study that demonstrated that mortality was substantially elevated when you did primary angioplasty. So this trial suggested between 1985 and 1995, angioplasty was considered a heresy. It was dangerous. It was irrational to do it. Now, I was one of the few believers that thought that primary angioplasty actually still had some benefit. And the reason was this: when we looked at what heart attacks were, is you have an acute cessation of blood flow to the heart. If you're going to fix outcomes, then you got to get blood flow back to the heart, TIMI3 flow. And you can see in this trial that in this slide that when you did angioplasty on the far right, angioplasty resulted in rates of TIMI3 flow greater than 90% in the vast majority of cases. And with thrombolytic therapy, it was anywhere between 30 and 50% rates of TIMI3 flow. So how could thrombolytic therapy be better than primary angioplasty? And this is the thing that drove us to continue to look at this. And what I subsequently concluded is that we got those trials wrong. These trials were randomizing the wrong thing. They were randomizing a combination of thrombolytic therapy and angioplasty versus just thrombolytic therapy. And so you have to be incredibly careful when you do randomized trials. Randomized trials are great, but if you randomize the wrong thing, you set the field back for 20 years. And basically between 1985 and 2000, enormous controversy about whether or not angioplasty was successful or not. So I want to really be certain when we start doing trials of mechanical circulatory support and cardiogenic shock that we're randomizing the right question. And so subsequently in the TAMI trial and 26 other trials, when angioplasty was compared head-to-head to TPA, it was definitely superior. The rate of death or myocardial infarction was significantly better. The other thing about this trial that we learned, if you look in the middle, in the group that had the most benefit, the mortality benefit, was the anterior MI or the high-risk cases. And that makes sense. If you have something that's therapeutic, it's going to largely affect the highest risk patients and have less effect on the lower risk patients. So those are the things that we learned. You have to randomize, ask the correct question, and randomized trials for all of their benefit may lead you in the wrong direction. So now going into mechanical circulatory support, and again, I want to compliment Dr. Thiele because he's done a lot of the early pioneering work in randomized trial. The balloon pump 1 shock trial was looking at the efficacy of balloon pump. And what this to me is very analogous to the combination of streptokinase to primary angioplasty. If you want to get a patient out of shock, you have to get them out of shock and you have to support them. And if you look on the left, in compared to medical therapy, balloon pump really provided very little incremental increase in cardiac power output. And that really is the reason I think that balloon pumps were not effective. They really didn't improve the hemodynamic outcome for these patients. And then subsequently, in the randomized trial that he conducted, there was no benefit to balloon pumping. So I think he and I would both agree that on a routine basis, that balloon pump really has no efficacy in management of acute cardiogenic shock. It's really kind of astounding and aggravating to me that in the United States, 40% of doctors are still using balloon pump to manage cardiogenic shock. So either you believe randomized trials or you don't. If you believe in the trials and you shouldn't be using it, then why are you using it in these patients? And I think it's largely because they're desperate to do something to try to improve the outcome for these high-risk patients. Now, this is a patient that we treated in the National Cardiogenic Shock Initiative. A 59-year-old gentleman came in with a large anterior infarction en route to the cath lab. He had an arrest. He had no circulation. As we were doing CPR, we got the catheter in, put the Impella in, and then you can see that the patient stabilized. He had a total occlusion of the LAD, which was subsequently opened with a stenting. We were concerned that he was going to need an LVAD and all that. The patient left the hospital a week later with an ejection fraction of 52%. Now, sure, it's an anecdote, okay? But if you repeat these anecdotes, then this is now in 37 patients in the NCSI, almost 10% of our patients, they were actively having mechanical circulatory support with CPR, and they had a 68% survival. So these patients would never get into randomized trial. And similarly, in out-of-hospital cardiac arrest, 85% survival for these patients and 72% if they arrested in the hospital. So these patients are so ill, at least in the United States, they would never get into trials. We looked at now in the National Cardiogenic Shock Initiative, looking at the SCI classification, a third of the patients were in stage E. These are the patients that had cardiac arrest that were just absolutely incredibly ill, and we were able to achieve a 58% survival for these patients. If you take a look then at the outcomes, and this is data that we've just presented at SCI. If you take a look overall at the 30-day survival in patients with medical therapy in the red line, a 44% survival from the original randomized shock trial from from Judy Hockman, survival was increased to 53% with revascularization. But then the other trials, the culprit shock, the balloon pump shock, have not really showed much of an increase in survival for patients. With the NCSI, with mechanical circulatory support with Impella, we've been able to achieve the survival up to 77% for Class D and Class C and D, and 68% for all comers. So I think that this shows that the survival is going to get better. We know how to use this device better. We know how to properly alter pharmacologic therapy and specifically use these support devices with right heart catheterization. So now I think it is time, and we are ready, and we are going to be doing a large randomized trial. Greg Stone, Naveen Kapoor, and I are going to be heading the Recover 4 study, which will be a head-to-head comparison. But I'm confident based on this data that outcomes are going to substantially improve. We've had 40 years of therapies for cardiogenic shock, and we've kind of been stalled at a 50% survival for the last 30 years. So I do believe that mechanical circulatory support is going to improve the outcome for these patients. Thank you very much.
Yeah, thank you very much. So I think it was relatively easy for me now to give the counterpart, because if you look for the talk from Dr. O'Neill, has he shown any randomized clinical trial for patients with mechanical circulatory support? I missed it in his presentation. And this is my disclosure. My major disclosure is I believe in evidence and I follow evidence, and evidence, the highest evidence, is randomized clinical trials. And this is what I will try to show you with respect to mechanical circulatory support. So this is what we have available, at least in Europe. You all know these devices, IBP, Impeller, Tandem Heart as well. And we also have in Germany and in Europe the IVEC 2L. And for sure, we also have ECMO. You have seen this. Probably in my life, I've shown this slide several hundred times. But if you would have asked me in 2012, I was also a believer in the intra-aortic balloon pump, and also our ethical committee said, you can't do a randomized trial where you treat patients without an intra-aortic balloon pump. And it took us a year to convince the ethical committee to do this trial, because everybody was believing in the intra-aortic balloon pump. But as you now can see, the intra-aortic balloon pump has no effect at all. And that's the reason why, at least in the European guidelines, we now have a class 3 recommendation that the intra-aortic balloon pump should not be used on a routine basis. In Europe, we follow more evidence. So we do not use the intra-aortic balloon pump in 40% of the cases anymore. So in Germany, it's down to less than 5%. And it's mainly used by the surgeons, but not by interventional cardiologists anymore. And you can see what our trial has, how our trial has influenced the clinical practice. These are US data. So intra-aortic balloon pump is going down, and you have the steep increase in Impeller, Tandem Heart, and also ECMO use. And this is what happened in Germany. So a very steep increase in ECMO use, which is maybe also influenced by reimbursement. And also because we have seen that the intra-aortic balloon pump does not work. And now we really want to have something which is more active and which hopefully will lead to a reduction in mortality. But now we are looking for evidence. So this is important. So currently we have 4 small randomized clinical trials comparing Impeller or Tandem Heart versus intra-aortic balloon pump. And we were able to do an individual patient-based meta-analysis. And this is what you can see it here. I agree, this is limited because we have only 150 patients, but there's really no effect at all on mortality if you use active mechanical circulatory support versus intra-aortic balloon pump. And maybe most importantly that you have to look on this. There's an increase in the mean arterial blood pressure if you're using active mechanical circulatory support. There's also a small but significant decrease in arterial lactate, at least immediately in the cath lab. But you also have more bleeding, as you can see it here. And I have learned, and I know it from many registries and trials, bleeding increases mortality, and we can't ignore this effect. So these devices increase bleeding, and this is what we have to keep in mind. So in the moment when we do not have large-scale randomized trials, usually what we do is we use registry data and we try to do matching, which is not perfect, but it's at least the best what we can do if we do not have enough randomized data. And I will show you the data. So the large-scale matching studies, this is one we have done from IBP Shock 2, comparing it to an Impeller registry. Looking for this, no effect at all on mortality, but significantly more bleeding, more peripheral complications, more life-threatening severe bleeding, and also more sepsis with the active mechanical circulatory support. Then you all know these highly discussed registries from the United States. 28,000 patients, 48,000 patients, and they try to adjust it. They try to do matching. More deaths, more bleeding, more acute kidney injury, more stroke with Impeller in comparison to intra-aortic balloon pump. And then you also have this registry published very high in JAMA, as you can see it here. Altogether, 3,300 patients have been matched in this, this comparison. More deaths, once again, more bleeding with the Impeller in comparison to control. In this case, they use the intra-aortic balloon pump. So based on this, currently I can't see any registry and I can't see any randomized clinical trial which has shown a reduction with active mechanical circulatory support for patients with cardiogenic shock. Looking for ECMO, this is what we do in Germany. registry data. We have some data there, but it's very, very limited. This is a meta-analysis where there may be a reduction in mortality if we are using ECMO in comparison to control, but very limited, less than 100 patients so far. Taking all the things together, and this is what I mentioned, I believe in evidence, I believe in randomized clinical trials. So early revascularization can reduce mortality based on the shock trial in patients with acute myocardial infarction and cardiogenic shock. Everybody probably also would not have believed that carpet lesion-only PCI, so the more minimalist approach, will reduce mortality in patients with multivessel coronary artery disease, as we have shown in the carpet shock trial. And now, hard evidence, pure evidence, intra-aortic balloon pump does not reduce mortality. And if we are using active mechanical circulatory support in an unselected way, and this is what Dr. O'Neill is currently doing, then we will not be able to show a reduction in mortality. And this is maybe the most important slide. We are also using active mechanical circulatory support in Leipzig, but probably patient selection is key. If you put in a device in every patient, and we currently know that 50 to 60% of the patient will survive without any device, but if you put in a device in this patient, you will not change the outcome of the patient, or maybe you will induce harm, and you maybe will induce bleeding. You may also induce other complications which will lead to death of the patient. And I've seen these patients in clinical practice. Honestly, I believe that maybe 20-25% may have a benefit of active mechanical circulatory support. And then there are also patients who are in a futile situation. You can put in the best device in the world and you will not change the outcome, in particular those patients who have undergone resuscitation before. And these are currently roughly 50% of the patients getting into our cath labs with acute myocardial infarction and cardiogenic shock. This is what we called cohort A, no device. This is what we called cohort B, yes, a device should be used. And this is where you can discuss at least to use the device as a bridge to decision until you know the neurological outcome of these patients after approximately 3 days after admission to the intensive care unit. The good news is we have ongoing randomized clinical trials which will give us the answer if we are really able to reduce mortality for patients with cardiogenic shock. In blue, you can see the already performed randomized clinical trials. In red, you can see the ongoing trials. We are currently doing an ECMO trial, ECMO versus no ECMO for patients with cardiogenic shock. And I've just seen the interim analysis, so now we have included 225 patients. From now on, it will take us approximately maybe 1.5 years. Then I can tell you if ECMO in severe cardiogenic shock patients will be able to reduce mortality. There's another European trial, which currently has included only 20 patients. Then we also have the DANGER trial, the Danish Germany trial, randomizing patients to Impeller in comparison to control. They are still struggling with the inclusion rates, and they have, so far I know, nowadays included a little bit more than 210 patients. So this is also an important trial, but we need this evidence to really can say, okay, active mechanical circulatory support is able to reduce mortality for these patients. Thank you very much.
Thank you, Dr. Thiele. Really, really great discussion. And, your that second to last slide is really the slide. And I think like you're all basically saying the same thing that Dr. O'Neill is saying, that what he's trying to do is because it's hard to identify who are those patients in the right side of the panel. And you didn't tell us that. So what I think Dr. O'Neill is saying is that if we apply it to most cardiogenic shock, you will get some benefit from that bucket of patients that you just described as the patients where we could see a benefit. Can you?
I think we're saying the same thing. If you have a really low risk patient, you're not going to have much benefit. And at the other extreme, the patient's probably futile. It's just trying to find the sweet spot. But what we've been trying to do for the last 4 years is to really optimize the use of Impeller in cardiogenic shock. For instance, 40% of the patients have severe RV dysfunction. if you use Impella, just the left-sided Impella alone, and don't do anything for the right side, you're going to have a futile outcome. And nobody knew that 5 years ago. So I think we have a very good algorithm now that we're going to ultimately test. Because if we get it wrong and it does work, it's going to take another 20 years to figure it out.
Dr. Thiele?
Yeah, it's difficult to say which patient really have a benefit. That's currently what we do, at least in the cath lab or in the ICU. It's a gut feeling. So often we look for lactate, but I also looked it up. What was the age in all the randomized trials and also the registries? Usually the age is in the range of 60 years. This is what we also have to keep in mind. And all the large-scale randomized trials, like IPP Shock 2 and also Calposhock, the median age of the patient was a little bit more than 70. So what we currently do, we do already a selection in these patients. So we are treating the younger patients with active mechanical circulatory support in clinical practice. So most of the patients who come in currently are much older, and probably this is what we already do in clinical practice, that we do not use active mechanical circulatory support in these patients.
This is great. I can't wait for these trials to come out because I do believe the randomized trials will give us some answers.